I think you can just find the slides in your lecture. We ended with a slide that said dying patients. Yes? I think so? Okay, so if you are working with an actively dying patient, you need to be there present for the patient, but you need to be present for the family members as well. These patients need a lot of physiologic support. You need to suction them if they need suctioning. You need to keep them clean and dry if they're incontinent. Wet their lips or moisten their lips with some of those, what do you call those, Toothettes or the sponges, whatever they're called. So all of the personal hygiene measures. If family members are at the bedside, they want to see their loved one that's actively dying to be well cared for. Remember that it's a privilege to be with patients at the end of life. I told you yesterday about my first patient having died, and I have to just be honest with you, it had no effect on me. I was kind of like, wow, I was really surprised that I was dumb enough not to know that the patient had died on me, but I wasn't emotionally connected to that patient. I think part of the reason was that I was so focused on doing tasks, doing that bed bath, that linen change, that whole, when you're just focused on the thing you have to do. And as you get more experience, you will become much more connected to the patient. And you will, in fact, what is that?
I think the rent picked up and just created some ambiance to the lecture.
Sounded like a truck or something coming through. So if you are caring for a patient who's actively dying, provide really meticulous care for them. Be aware of what their needs are instead of just focusing on little tasks like I did. I think you will grow in that experience in terms of how to deal with the families of dying patients as well as dying patients, and you will feel connected, and you will feel a sense of loss when the person you have cared for actually dies. So there was a student whose patient died and probably had the same experience I did. Didn't feel a sense of loss, didn't feel a great deal of grief because that was the first patient, you didn't know what to do, right?
I asked the nurse, I was like, am I heartless because I'm not crying that my patient died? She goes, no, you've only known him for a few hours technically, and she's like, I've only taken care of him for today and I'm not crying, so
Yeah.
it made me feel better in that way.
No, I didn't mean to say you would cry for every patient that dies, but you do have a sense of loss. It's a human being who's lost their life, and you have a sense of loss, I guess is the best word for that. You're grieving that someone who was important to the family members who may be in the room, that they're all grieving and that the person wasn't able to survive. Pain control is really important, and sometimes at the end of life, they give them a morphine drip. Patients will often be on a morphine drip. They will discontinue everything in many cases if they're hospice, so they won't have an IV, but they will get morphine. They have morphine that will melt under the tongue. They will have patches for pain management that will be absorbed through the skin. So if they're truly on hospice and everything has been discontinued, you won't see that medication in an IV drip. If they are still with IVs and they have other, measures that are still running on, everything hasn't been discontinued, the pain meds will be given IV. So it all depends on the type of status that the patient's in. And often the question is, this patient's supposed to have a dose of morphine. The respiratory rate is already at 10 or 9. So if I give this dose, and I'm going to put this patient over the edge, what do you think? What's the answer to that question? Is that considered euthanasia? No. It's a comfort measure. The patient's actively dying. They're going to die within a short time frame in most cases. If they look like they're uncomfortable or they're becoming restless, then it's a pretty good indicator that some pain management would be appropriate. If that dose causes the patient to stop breathing or the respiratory rate goes really, really low, that doesn't mean that you overdose them. The patient is in fact actively dying, and the drug will have effect or impact on them. So don't worry about that. If they look uncomfortable, medicate them. Relief of respiratory distress, again, we give morphine. Morphine is a wonderful, wonderful drug. It relieves not only respiratory distress, but it relieves the anxiety related with respiratory distress. So it's a great drug. We give them Lasix. Why do we give them Lasix? We're not trying to make the kidneys work. Yes, if they're going into congestive heart failure, often the Lasix will help to reduce that large volume of fluid that's coming back to the heart. The anticholinergics, if they have lots of secretions in the oral upper airway, they have a tendency to start, the fluid should start accumulating. It's called a death rattle. They start kind of gurgling. You can relieve that by giving them anticholinergics and by raising the head of the bed up to allow those oral secretions to drain. A fan in the room will help to facilitate breathing. They've done a lot of research studies, and for the most part, it demonstrated that oxygen at the end of life has very little impact. So if they look like they're having some sort of difficulty breathing or they're gasping for air, it can be real uncomfortable for family members to see that and distressing for them. Often a fan, the patient feeling airflow in the room, is more effective than giving them O2. If you're in a really stuffy room or it's really hot, and then you feel the air flowing from a fan, does that make a big difference? So that's often very helpful for patients. Facilitate rest, turn them frequently, keep the room quiet. Keep in mind that it's not smart, not a good idea for the family members, knowing that this person is dying, to start planning the funeral and who's gonna do what at the services. So the patient can often hear until the end. So you don't want them to be actively dying and somebody planning in their room what kind of services they're going to have for the patient or where they're going to bury them. So if you're in the room and that's the kind of discussion that's going on, what's the best approach? Yeah, tell them about it and they may not want to step out because they know their loved one is actively dying. Just remind them that it's very likely that your loved one can still hear you, so it may become distressing to hear you planning their funeral while they're still alive, and please do that if you need to step out of the room. You need to probably assist the patient turning them. They won't be able to turn them and position themselves anymore. Nutrition, hydration, and elimination. Lots of studies have shown that as a patient starts to die, they're actively dying, giving them any food or fluids is more distressing than helpful. Why do you think that is? And some family members just insist, just one more bite of Jell-O or take a sip of this water. Why is it more distressing than helpful?
Because everything's slowing down inside.
All the systems are slowing down and shutting down. They're not going to absorb it. They're not going to be able to digest anything. So patients have been shown to be much more comfortable to just not giving them any food or fluids. And I think in your notes it says cessation of food and fluids is a natural process. It is not painful. They probably are not hungry or feeling a sense of thirst because all of the systems are slowing down. Provide measures related to sensory changes. What does that mean? If they're cold, add some blankets so they're not shivering, so they're comfortable. What else? As people are dying, those patients who are dying and they're still awake and alert are able to participate in some conversations or acknowledging the presence of people, their vision starts to go. So if they really want to see people, they need to be close to the bedside and lots of lights on so they have enough light to see who's there. Our tendency is to just calm, play some calming music, turn the lights down, but then the person who's dying can't see. So bright lights help for them to see if they're still alert. If they're, kind of going in and out of consciousness, then that's not important. But if they want to see or talk to someone, turn the lights on. If they have any sort of dyspnea and they start to gasp for air, what are you going to do? Do what? You can sit them up, turn that fan on. What else? What is the most effective drug to relieve the anxiety associated with dyspnea? Give them some more morphine. Okay? It's distressing for family members to see somebody struggling to trying to catch that last breath. Then at the end of life, you see lots of different things going on. I think I mentioned yesterday that I didn't notice that my patient's limbs, upper and lower extremities, had turned kind of bluish. Mottled, it's called, mottled skin. That's due to pooling of blood in the tissues. It's no longer perfusing well, and so it starts to settle in the tissues and dependent areas. The heart can't pump blood, perfuse all of the periphery anymore, so you'll see that becoming kind of like cyanotic looking, mottled discoloration type of thing. If you're taking care of a dying patient and family members get concerned, you need to just explain to them what's happening. As far as the skin is concerned, keeping them nice and clean is important. I mentioned the breathing already. If they are looking like they're gasping, you give them the morphine. They will start having respiratory irregularity. And what's that pattern called? Cheyne-Stokes. So they'll have Cheyne-Stokes respirations. They'll have breathing. It gets slower and slower. And then they have periods of apnea, right? And that periods of apnea will lengthen over time until maybe there's a minute between breaths. And you look at each other in the room, the family members, you make eye contact, and sometimes it's like, I think this was it. And then some of those patients will surprise you. They'll take another breath. But when it gets to be that long a time in between, they're pretty close to taking their last breath. So when they start having Cheyne-Stokes respirations and those periods of apnea, they start to lengthen, that's pretty much very close to the end. As far as bowel and bladder, as far as urine output, if they've been dying actively for a couple of days, they will have had no urine output. The kidneys have shut down, or very little urine output. When they actually get close to dying, their sphincter control is lost, and they may have involuntary both bowel and bladder incontinence. I already mentioned the pain control, keeping them comfortable. When a patient dies, if it's a patient who has family members at the bedside and they have all kinds of things hooked up to them, you can just quietly start to discontinue or to remove some of that equipment that's at the bedside. If they've been there all along with the patient and things are, they just don't have any problem with all of that, then you can just leave them alone, tell them you will be right back, or ask them before you leave if there's anything you can do for them. Tell them how sorry you are for their loss. Stay with them for a little bit, and then let them have some quiet time. If you have a patient who died suddenly and hasn't been under the care of a physician, they're automatically a coroner's case. If they're a coroner's case, you may not remove any of those lines and catheters and things that have been inserted in the patient. They need to stay in place. If they're not a coroner's case, you remove everything. IVs, Foleys, breathing tubes, everything is removed. And how do you know if they're a coroner's case?
If they just have surgery, like 12 hours before.
They're a coroner's case, but if they were under the care of a physician and then they die maybe post-op, they're not necessarily a coroner's case, but they may be a coroner's case if they came in due to some sort of violent act, a gunshot wound, a stabbing, or whatever, then they're automatically a coroner's case. So you will know, it'll say on the chart usually that the patient's a coroner's case, and so if that's the fact for your patient, don't remove any of the lines. Disconnect them from the drainage bags, clamp them off, but don't pull them out. If the family is not in the room with them when they die, then take all the lines out, make the wash them up if they need to be cleaned up, and then the family will have been called so that when they come in, the patient looks like they're really quietly asleep. Pull the sheet up to their neck and put a pillow under their head. If you don't put a pillow under the head has a tendency to turn kind of cyanotic looking because the blood starts to settle in their head. So put the head up on a couple of pillows so that it'll drain out of their head. What else? If the patient has just been coded, it's really important that you clean up the room. Many of you probably haven't seen a code, but they tear packages open, there's stuff everywhere, and the room looks like a tornado has struck. So if your patient has just been coded and then died, and they've called the family, or the family wasn't present at the code, then clean up the room before you bring the family in. A lot of hospitals allow the families to be in the room when the code is called. So if they were present during the code, and they saw all of this, paper wrappers and all these supply things flying around and up on the floor, you don't have to ask them to leave. But it's kind of shocking to bring a family member in such a big mess after a code. So do help to sort of clean that up. If you are cleaning up after a code, be mindful of sharps. There may be sharps on trays. You have to sort of sort out what's disposable and what needs to go in the sharps container. Very, very carefully look at those trays before you throw them kind of, all in one piece in the trash so that no one gets stuck with a needle or a sharp. Spiritual support. Oh, any questions about dying? Yes.
If the family's in the room when the patient goes to start code, do you get them out of the room automatically, or do you let them stay in the room?
It all depends. Some hospitals have a protocol that clearly allows family members to stay for the code. If they become hysterical, ask them to leave or have someone take them out of the room. If they're quietly standing in the corner of the room and they're watching, frequently after a code, family members have said, I know absolutely everything was done. I was glad I could see that there was nothing else that could have been done. Sometimes family members wonder after they suddenly died if in fact everything was done for them. It all depends. If they're starting to panic or they're starting to just, look like they're going to pass out, or if they're looking like they're going to have a negative reaction, ask them to leave the room. But how many of you work in hospitals? Do they allow family members to stay during a code? They make them stay.
In the ER. Yeah,
Okay.
They bring them back, even if they don't want to be back there. They make them stand in the back.
Oh,
They have
okay.
to be there because, like we said, if they want to make sure
Yeah.
everything's done, so they make them stand right there and watch.
Okay, and if they don't want to watch, that's an option for them to just
If they
leave.
don't want to watch, but they're going to be in the back.
Oh, they do expect them to stay in the room?
There's like curtains.
Oh, okay.
In the ER, and so they're right there able to watch, and they can turn the other way if they don't want to watch, but they're going to be back there.
That's a giant change from maybe a decade ago. The code was called, everybody was cleared out and nobody got to stay. And now they realize that those family members can benefit from just being there, watching to see what is going on, that, every effort is being made to help them to survive once they've coded. And then they can actually say their goodbyes immediately if the code isn't successful. That's nice to hear that they make them stay, or ask them to at least come back if they're not in the
You can
room.
come back here, and then
Okay.
also a lot of times the family just tells them to stop.
Oh, okay.
They've done a lot.
So don't do this anymore type of thing?
Yeah, like the doctor will come and talk to you guys about it's been 10 minutes or whatever.
Yeah.
Like they'll tell them to stop. They give us
Okay.
that time in there.
So it can be really beneficial to have the family members in there. That's good. Anybody else?
We usually hold the family out front.
Hold them out front and not have them go at the
We
bedside?
usually wait until the chaos is kind of over, unless it's something where they have the patient as it,
Yeah.
full code, and they have G-tubes and everything. We're like, you want to see what happens to your poor family, like what you put them through? But generally, we kind of hold them off until, because it's so crowded.
It is very crowded during a code, and it is chaotic.
If they desperately want to come back, we'll let one or two back, but we still kind of hold them out.
Okay. So different hospitals have different protocols. I'm pretty sure that if it's a pediatric patient, they encourage the family to stay. Yeah. But adults now too. A lot of places we've heard two scenarios: bring them back, and if they really want to, you let them stay. But some some nurses still discourage the patient from staying, so it all depends on the individual nurse as well. And it depends on how they've been adapting to the sense that this loved one is actively dying or may not survive the resuscitation. Spiritual support, it is in your job description as a nurse to ensure that the patient's spiritual needs are met either directly or by referral. So if you have a dying patient and they have spiritual needs, it's your responsibility as a nurse. It's in your Nurse Practice Act, which didn't you review that in 112? You remember that component of your Nurse Practice Act? It's your job description. So how do you determine if you can meet their needs or whether you need to make a referral? How do you decide that? Do what?
The goal, the outcome.
The outcome, the goal that you're trying to achieve? So if you have a patient who says, you know, I really, I am, whatever, Catholic, and I'd like to have last rites. So can you provide that? No. So you need to call the chaplain. What if there's a person who says, well, we have all kinds of religious sort of procedures, protocols that we go through when a family member dies. We would like to perform those rituals. Depending on what it is, you need to let them do that. I had a patient once who was an American Indian. I'm not sure what tribe it was. And the family members actually came in with like mud, and they put it on the patient's feet so they could walk or to transfer from this life to the next. Whatever they need to do as far as their own rituals at the end of life, you need to allow them to do that. We do not allow them to light candles in those hospitals. So no candles.
What about pictures?
Pictures, lots and lots of families want to take pictures and send them to those who aren't there. If the family members want to take the pictures, they can take pictures. Yeah.
We'll make hand and feet casts or molds for the parents.
For the little ones that die? Well, that's a nice gesture. They usually take pictures too of like a stillborn. The shock of the whole thing is just huge for the family members, the mom and the dad. And then they will come back and make a little package of maybe the handprint and the footprints and the picture. And very, very nice gesture because that's not something they think of at the time. So yes, a family, you can't take pictures and, you know, if they hand you the camera and say, could you just take a picture? Have the family members take the picture. Okay? And don't use your camera in your pocket, so your cell phone or whatever you have. So typical needs of dying patients: forgiveness and reconciliation with God and human relationships. So they want to make the last phone calls, talk to family members they've had issues with, and just settle things at the end. Lots of prayer and religious service for some. Others don't want anything. So just the family members will tell you what their needs are, or the patient will tell you, and then refer them to whatever clergy they have on call at the facility where you are. So symptoms of almost dead, imminent death. They'll have very little or no urine output. Their extremities are cold and mottled. Vital sign changes. The significant one is that Cheyne-Stokes respiratory pattern. What happens to blood pressure? Drops down very, very significantly. Everything just goes lower and lower and lower until the patient's life ends. That respiratory congestion is called a death rattle. Sometimes suctioning helps, just raising them up on a couple of pillows or raising the head of the bed up sometimes is very, very helpful. That's really disturbing to the family members, that it sounds like they're choking. Okay. And then in many hospitals, nurses may declare a patient dead. In other places, a physician has to declare the patient dead. So again, it's the thing that's relevant to the facility in which you work. If the nurses do declare the patient dead, then often it's the supervisor instead of just a staff nurse. What do they do where you work? Who declares the patient dead?
The doctor.
The doctor in all cases? Okay.
Sometimes the house officers.
which is a physician,
No, the nurse, I'm sorry, the nursing,
the nursing supervisor?
Yeah, nursing
Okay.
supervisor.
Yeah, depending on the hospital, they may not have house officers. They may only have attending staff who are private physicians and not a medical staff that's there around the clock, like residents and interns. And so they'll have a protocol that allows the nurse to declare the patient dead. So there's absence of all vital signs. There's often loss of sphincter control, so release of stool and urine. There is absolutely no response. The body color is very pale looking, waxy looking. The eyes may remain open. If they're open, close them gently. The jaw may fall open, so they may actually be having their eyes wide open when they die. And again, if the family isn't there, then gently close their eyes. Some hospitals ask you to put the arms at the side, and others have you cross their arms over. It doesn't really matter what you do, but whatever the protocol is sort of what you follow. If the family is not there and you're preparing them for viewing by the family who may be on the way, then comb their hair, put a clean gown on, put clean top linens on, make sure that they're nice and clean and that they look like they're resting very quietly and peacefully. It says to remove jewelry or tape it in place. We often ask family members who come to take it with them, and that you need to document what it is you gave to whom. Sometimes family members come back and they say, I need to pick up my family member's whatever, their ring, their watch. So document what you gave and describe it generically. Yellow metal ring with a red stone, okay? White metal band with a white stone. A watch, white and yellow metal, that sort of thing. So do indicate who got it, so that it's not a matter of the hospital lost it. I think that's it for... someone asked, what do you do if the patient is an organ donor? What do you do then?
Usually keep them viable for a much longer period.
Yeah, if the patient truly has been identified as an organ donor, they are often not the type of people, as far as heart and lungs, who would have a card in their wallet saying, I want to be an organ donor. Often the organ donors are people who have come in from some sort of traumatic injury. They determine that they're brain dead, and then they will harvest their organs, heart, lungs, tissues, bone, and all of that sort of thing. If they're not already on a vent, they will have to intubate them and put them on life support, because those organs have to continue to be perfused. So if you have an organ donor, the patient has to be declared dead, and they declare them dead if they're brain dead. So you're truly considered dead if you're brain dead. So your heart will still be beating, you're still breathing because you're on a vent, and you will have vital signs, needless to say, but they will keep the ventilator going and then, as soon as possible, harvest those organs. There have to be usually 2 physicians that declare that kind of a patient brain dead. They'll do cerebral perfusion studies and EEGs, and then a physician other than the physician assigned to the patient has to also concur that the patient's brain dead. So you can't harvest organs if they're in a vegetative comatose state. They have to be brain dead. So brain dead is considered dead.
What's the difference? You can be comatose like for years or brain dead.
What's the difference?
Yeah.
If you're truly brain dead, you won't live years. Everything shuts down. You're dead.
No matter how many machines you have.
No matter how many machines, everything starts to deteriorate rather quickly.
We do a test that's called the apnea challenge, and basically it's putting oxygen down their throat, and they watch the end tidal CO2. Based on that, they will declare it.
Okay.
Along with all those other
All the
tests
other
that
things,
you
the
mentioned.
cerebral perfusion, the EEG, and then they'll maintain them on life support until they can obtain the organs for transplant. Okay? All right. Questions? On to Module 4. And Module 4 is really quick because you already know most of it. It's real familiar information because infection control and all of that We had to teach you that before you went into the clinical setting. So we can move along rather quickly. So Module 4 is identification of a safe and effective care environment. And interestingly enough, it starts with delegation. So did any of you wonder why a safe and effective care environment would include delegation?
So no, who does what?
Yes, as a nurse, you're going to be delegating. As a nurse, you may work with other licensed people, LVNs, or licensed practical nurses. You may work with CNAs, whatever they call them, patient care technicians. There are other people who provide care that the RN delegates to. So delegation is entrusting the performance of selected nursing tasks. You may not, at any point in time, ever delegate any component of the nursing process. So you can delegate tasks, but no component of the nursing process. So what are the components of the nursing process? Assessment, diagnosis, planning, implementation, evaluation. So that nursing process, which is really the essence of nursing. You cannot delegate any of that, but you can delegate certain tasks. So if you are delegating a task to someone, you need to know that they're competent to do that and that they know the task that you're going to delegate to them. So what are some of the benefits of delegation? You can share the workload. We all are now finishing our geriatric rotation in long-term care. And did you notice if you had RNs, were they right at the bedside taking care of the patient? No. Who provided the bulk of the care? The CNAs. And who did the meds? The LVN. And who did the treatments? The treatment nurse, which in many cases is an LVN, but it could be an RN. Depends on the facility and the type of patients that have procedures that need to be done. They will have an RN to do IV therapy and TPN and all of those things. So how does a nurse determine what you can delegate? How do you know, if you're the nurse, what you can delegate to the LVN? The scope of practice, yes. You're going to get more of that in the 4th semester. Everyone, you the RN, the LVN, the CNA, the physical therapist, the occupational therapist, they all have a job description. The ones that you're going to be delegating to will be nursing types of individual skilled people who will be, in most cases, LVNs and CNAs, or they call CNAs have different titles for them. So the teamwork works really well if the RN is in charge and then they have the LVNs and CNAs performing skills. So if you're going to delegate, you got to delegate the right task. So how do you determine what task you can delegate? Okay, let me give you an example. Can a CNA do oral suctioning? Would you delegate that to a CNA?
No.
In many places, they can do oral suctioning. They can't do trach suction, nothing sterile. But if the patient has lots of secretions, they can suction orally. So what if the patient just had massive oral surgery, and maybe they had head and neck cancer, and they have lots of sutures in their oral cavity? Would you delegate that CNA to use that Yankauer suction to suction that patient's mouth? No. So you, the nurse, have to know what it is you're delegating, and the patient who needs whatever skill provided. So you will have to evaluate and assess every patient you ever care for at the beginning of the shift. That's part of the reason. And then if the patient is just drooling, maybe they had a stroke and they can't really manage their oral secretions, you can delegate that to a CNA, oral suctioning in many cases. Certainly no sterile suctioning, no nasotracheal, no tracheostomy suctioning. The right person, you need to just figure out, should I give this to the LVN or the nursing assistant? The right communication and direction, you have to give clear, concise, correct, and complete instructions. So if you are working with a CNA and you're asking them to make sure that that person has a bed bath today, and the CNA has like we had in long-term care, 8 or 10 to 12 patients, then if that's all you ask them to do, they have the whole shift to do that, right? Wouldn't you think you have the whole shift to get that done? But if the reason that you ask them to do that is because they have a doctor's appointment at 10 a.m. and they need to be done and dressed to go to the doctor's appointment, you need to be specific and clear. And otherwise it won't get done at the time that you, in your mind, thought it would be done. So if you do give any sort of task to be delegated to someone, you need to give them feedback as to what it is you want and need, what the patient's orders are, and that if they need supervision, that you help them. So never delegate anything that you don't know how to do. Okay? So you can only delegate things that you know how to do, because if they need assistance, you need to be able to help out. Okay, so provision of guidance by an RN as far as delegation, so periodically you'll have to just check. Over time, you're working with people you get to know really well, and you know what their skill levels are. You don't have to check. But I had a CNA once, and I looked at the vital signs that had been recorded for the patients that had been assigned to me, and I was really quite surprised that all of their blood pressures were the same. And so a little anecdotal, when I was a new grad, my first job was at Harbor UCLA, and I was the only RN on the 3rd 3 West, still has 56 beds, only RN, 1 LVN, and 5 aides. Those 56 patients were mine. So now you think, the acuity was really different then than it is now, but nonetheless, I had 56 patients. So I delegated a lot, but that's when I noticed that every one of my patients had the same blood pressure. So I said, how is it that these 56 patients all have the same blood pressure? And she said, you know what? I just got certified. I never, ever had an actual patient to practice on. I just know that a normal blood pressure is 120/80. So that was an indication to me to supervise those blood pressures for a while till she got it right. So if you delegate anything, the accountability for that patient's care remains with the RN. Okay? So the RN retains accountability for the total nursing care, including everything you delegate. So you are answerable for what they have done. Does that make sense to you? So making decisions to delegate, don't delegate, like I mentioned, any component of the nursing process. You need to know that up front, not delegatable. So can you delegate, let me think, discharge teaching? No, it's part of the RN role, right? Can you delegate, vital signs?
Yes.
How about your head-to-toe assessment?
No.
How does that work when the LVN does it? But the LVN has to function under the supervision of an RN. So if you delegate that to the LVN, how does that work? And this is why we don't see LVNs in acute care anymore.
They can only collect data.
Yes, they can only collect data. We call it assessment for an RN in an RN's job description. If you look at the LVN job description, when they collect data, that's kind of what we call the patient assessment. They can collect data, but they can't interpret the data. The RN has to interpret it. So if the LVN, quote, collects the data and does the head-to-toe assessment, then an RN has to double-check that and validate that if there are any deficits, that's double-checked by the RN. So that's why in many places now we only see those LVNs in long-term care and clinics, because the RNs didn't have time to double-check the LVN's work as well, and they had to sign for that assessment, and so then they were accountable. So assessing the patient's needs, so evaluate. Sometimes you have to do things yourself. If you have a brand new patient who looks like they've had lots of issues, maybe they had a significant fall at home, you just may want to quickly do that bath. While you're talking to them, you can collect all the data that you need. You don't have to sit at the bedside. Talk to them while you're doing that quick bath. check their skin. 100% of all their skin has to be checked, so might as well do that then, especially if they had a fall and they have skin tears and bruises and all of that good stuff. And you might not want to delegate that until the next day to a CNA, even though usually that's the CNA's job. You need to, already mentioned, plan the desired outcome. Yes?
When checking the skin, like say that you weren't going to give a bed bath until later in shift, are you required by X amount of time into your shift to have done it head to toe? Or
Yes.
Okay.
Yes, and there are specific time frames. In many hospitals, they have standards for performance. In some hospitals, you have to do the head-to-toe assessment and the admission assessment on a new admit within the first 2 hours that they hit the door. In other places, they may give you 4 hours, depending on the acuity of the patients on the unit. It's unit standard, but you do have to do that head-to-toe assessment, and you must, at the time of admission, look at 100% of their skin. So some patients, they come in, they're ambulatory, and then you tell them, oh, you know, you need to take those pajama bottoms off. I need to check your backside to make sure you have no areas that where the skin is not intact, and they look at you like, oh, my goodness. But what happens is, if you don't check 100% of all of their skin, and then the next day it turns out they have some sort of a lesion of some sort, or maybe even a pressure area that you missed, it is now a nosocomial, a hospital-acquired pressure area. So if that's the case, they no longer get reimbursed for that if it does extend their length of stay, because it's hospital-acquired. It shouldn't have been. It's a nursing responsibility. So do not fail to look, even though they look like it's unlikely they would have any skin lesions or pressure areas. Check every square inch of skin. So with the bath, you need to do that. Even if they're going to do their own peri-care or they're going to take a shower, at some point on admission you have to check their skin. How do you assess the person's competency? What do hospitals require to maintain competency? Return demo, and how often do you have to demonstrate competency? Once a year. So if you know that as employees everybody's checked off, you don't have to personally check to see if they've been checked off on whatever competency they are required to have. Often there is a manual on the unit that has all the employees' names on it. It's often in the supervisor's office where it shows that they have complied with the annual updates. So if you recognize that someone is not competent in doing something, then teach them how it should be done. Give clear directions, and then evaluate and provide feedback. If you're working with let's say an LVN, and you have a patient who needs colostomy care, and they've never done it, and they tell you they've never done it, then what? Go to the bedside with them and teach them so that tomorrow you can delegate it to them. Otherwise, you have to do it again today and again tomorrow because they still don't know. Okay? So if you're delegating, don't grab back a delegated task. So if you delegated something and it still isn't done, don't throw up your arms in exasperation and say, oh, I'll do it myself. You haven't done that yet? I'll go in and do it. Don't delegate only tasks that you don't enjoy doing yourself. If you absolutely don't like to do colostomy care, don't delegate that colostomy care all the time to whoever you can delegate it to, the licensed person or the CNA. You need to be able to show the staff that you don't delegate things that you have a dislike for, and then give it all to someone else. Don't delegate beyond the staff member skill level. Happens every now and then we hear how that person lost their license. If you delegate to an LVN, sometimes patients' IVs are ready to run out. The RN will put the IV at the bedside. Have you ever seen that? And then when that pump starts to alarm, you hang the next bag of IV fluids. It's been years ago now, but the RN did that and said to the LVN, when the pump alarms, will you please hang the next IV? Can LVNs hang IVs? Yes. Yes. LVNs may start peripheral IVs. They can't insert PICC lines. That would be an RN doing that, the peripherally inserted central lines. But they can start IVs, and they can hang plain IV fluids, including fluids that contain vitamins, minerals, and electrolytes. If the electrolytes include potassium, they can only add a liter with a max of 40 milliequivalents of potassium. Okay, pre-mixed. They can't mix IVs. But so can they hang a piggyback or a K-Rider or no? So anyways, the nurse had worked with this LVN for a long time, asked the LVN to hang that IV. And so the LVN very conscientiously, the pump alarmed, hung the next bag. Well, the patient ended up having a cardiac arrest and died due to anaphylactic shock. What happened? The nurse had grabbed the wrong bag. The LVN did not check the label on the IV bag against the patient's ID band, and it was an IV antibiotic that had been mixed in instead of a piggyback, and the patient suffered a cardiac arrest. So who lost their license? The LVN. The buck stops with whoever does it. So if the doctor orders something that's way out of range and you give it, because that's what the doctor orders, you're accountable. Buck stops with you. The doctor doesn't get in trouble, because you need to know what the average safe dose is of a medication. So that's why you look up every med that you're going to give. Over time, you become real familiar with the type of meds you give. So know what you can delegate. In that case, the LVN, yes, could hang a plain, but not a medicated IV. They can't hang anything that has medication. So other than plain fluids, minerals, vitamins, and electrolytes, not to exceed 40 milliequivalents of KCl. So that LVN was prosecuted, lost her license. So just keep in mind that you shouldn't ask someone to do something that they're not supposed to be doing, but that LVN should have checked the labels and didn't. Don't delegate tasks at which you are not proficient, and don't reverse delegate by doing the job yourself. So have patience. So be clear in delegating if you want something done at a certain time or a certain way. So now we're going from delegation to quality assurance and assessment. Why is that part of safety? Safe and effective care environment. Those of you who work in hospitals, tell me what you know about quality standards, quality assurance, quality measures, whatever they call it.
Constantly being reviewed.
They're constantly being reviewed, and how do they review them?
There's usually a task force that oversees things like med errors or just
Yes.
calls or just whatever it may be.
Right. So they're looking continually. It's an ongoing process of quality assurance and assessment. So there are certain standards. There are, what are they called? The patient safety, what are they called? The National Patient Safety Goals. And every year those National Patient Safety Goals are revised and fine-tuned. Those National Patient Safety Goals that have been established recently are part of this whole quality assurance and assessment of providing healthcare according to professional and regulatory standards. So the regulatory standards are oftentimes the health department and the Joint Commission. Those National Patient Safety Goals are incorporated into all of these standards in the unit. So those National Patient Safety Goals that have been adopted in recent years include what? Those of you who work in hospitals.
Where they pass meds and how they pass them.
Okay, the medication administration, because there are so many med errors, they have developed standards that you can't interrupt the person who's giving meds. In some places they have a vest that they put on, and I'm not sure what it says on the vest, but it's an indicator that you shouldn't interrupt that nurse because they're preparing medications. What else? Sometimes they have a little circle of you can't trespass over this line if the nurse is at in the med station or at the Pyxis or whatever, so that whoever's getting the meds out can have that time to think and critically assess what it is they're doing. So what else? Yeah, JCO now comes in unannounced, the Joint Commission folks. Although often they know within sort of the time frame, but they come in unannounced. Some of those are the recent health, National Patient Safety Standards include preventing ventilator-associated pneumonias, and they'll have protocols to institute on every patient. They'll then review the chart to see if those standards were actually provided and adhered to. Improving the safety of administration of medications, the pumps that have to be used, the pumps that have to be double-checked by 2 RNs if they're narcotics, the insulin that has to be double-checked by a second RN, so this is the safety in using medications. Reducing the healthcare-associated infections. The Foley catheters are removed very quickly to prevent UTIs. Those are all very recent standards. The reconciliation of medications. If a patient gets transferred or goes home, we have to make sure that whatever meds we gave them in the hospital, if they need to be continued, that we give them that list, they have prescriptions filled, and that they will continue, and they know what meds they have to continue on. So lots and lots of patient care standards. They do get updated every year. So as far as quality assurance and assessment, all of you will be part of this. You will all be part of, if you're not collecting the data or you're not on the subcommittee or the team that is looking at a particular patient care standard, they will review the medical records that you have contributed to see if you adhere to the standards. So all of you are participants in quality assurance and quality improvement. Okay, so they're looking at data. They would expect like 80% of all of the patients will have medication reconciliation on the chart within 4 hours of admission. 100% of all the patients will have whatever the standard is at the time of discharge. Okay? Okay, so standards that are implemented define quality. And if you don't adhere to the standards and you don't reach the percentage that has been set as being a reasonable and ideal type of quality of care standard, then you will see notices. We only got to 70%. You got to get better. You're not documenting everything you should or whatever. You'll get those notices when you're a staff person. So outcome standards are the most measurable. We want to know what percentage of patients successfully got discharged after a total knee replacement or a total hip or an MI or whatever. Okay? And then those outcomes that are based upon the quality assurance standards reflect the results of the care provided. Okay? So we want to make sure that patients have safe and effective care. Good documentation is part of that. If you have poor documentation, then there's no way to measure if the care standards have been accurately implemented either. Poor performance increases your chance of legal liability as well. So part of performance improvement and a safe environment is to prevent falls and injury. Those are part of those patient care standards that I mentioned, those annual standards. So how do you prevent falls?
Depends on the facility.
Depends on the facility. Yes, absolutely. So how did they prevent falls where you were for long-term care? Call light within reach at all times.
Sometimes if there was an order of bed rails up or...
Okay. An order for the bed rails up or the bed to be totally almost on the floor.
Signs on the door.
The signs on the door, the yellow sign or a yellow star or a magnet, yellow socks, a yellow bracelet. It'll say fall precautions. Oh, and there's usually a tag on the chart. Okay, with an electronic medical record, you just need to, it's in the care plan. Med errors. What causes most med errors?
The nurse being distracted.
The nurse being distracted, number one.
Poor handwriting.
Poor handwriting. With electronic medical records, we'll get away from that.
Being in a rush.
Not adhering to the 6 rights. What are those? The right
time,
Drug dose, time, route, patient, and documentation, right? Okay. So how many patients die every year due to poor adherence to standards, injuries, including all those med errors, people falling out of bed? How many people a year die? How many? 100,000. That's an awful lot, don't you think? And we don't want to contribute to that, but statistically we will. Some of you will contribute to a patient's demise by making errors. So hopefully you will be conscientious enough that the injury that you cause or the errors you make won't cause the patient's demise. Not too long ago, back to med errors, there was an actor, and I can't think of his name, whose twins received too much heparin. What was his name? Dennis Quaid had twins at Cedar Sinai, and instead of giving 10 units, they gave 1,000 units of heparin to newborn infants.
They gave adult dose instead
Yes.
of
Yes. So when that first happened, they interviewed the nurse. Guess what the nurse said?
the pharmacy sent it like that.
The pharmacy sent it, and no, the pharmacy. Well, they sent the vial. Yes, but it had to be drawn up out of the vial. So guess what the nurse said on TV? I didn't read the label. I thought, oh, how would you even dare say that? I didn't read the label. I just read heparin. Well, there's a drug, heparin. There's a dose. It was supposed to be, I think, 1,000 or 10 units. I mean, 10 units or 100. I think it was 10, but 1,000 was given. So the nurse had the audacity to say, I looked to see if it was heparin, but I never looked at the dose. Can you imagine? What happens to people's common sense and adhering to keeping patients safe? Those two infants did survive, but we have this sort of thing all the time. And guess who got blamed? The drug company.
yeah,
The manufacturer.
The colors
Because they should change the labeling. Well, if the nurse had read the label, hello? The nurse would have known that it was 10,000 units or whatever and not 10 units, right? I have had students who couldn't tell the difference between 1,000, 10,000, 100,000, or 1,000,000 units. They couldn't read the numbers.
I think what she said was that they changed the color of the vial,
Yeah.
and so all she saw was the color.
I thought the pharmacy had said, like, they usually have a supply for kids,
Huh.
and that's automatically what they give.
Okay,
But this one.
but listen to yourselves.
Oh, no, it's absolutely ridiculous.
What happened to reading the label? You know, they said they changed the color. They said that they always send a pediatric dose. Well, it doesn't eliminate the need for you to read the label. I have students every semester, we start giving insulin, and I say, okay, look on the computer screen and tell me what you have to give. Insulin. What have you got there? Insulin. Well, it says regular. What kind of insulin do you have? Insulin. Okay, well, read the label again. And the student will read the label and say, okay, now look at the screen. What is it you're supposed to give? Insulin. They'll have NPH. But all they see is insulin and not regular. So every label has to match what's on your order. If it doesn't match, it's probably, in the case of insulin, the wrong insulin. Okay? But you can't blame someone else for you not following protocols. Oh, they changed the color. Well, different manufacturers have different colors, believe it or not. Oh, I used a needle with the orange tip. Well, in this hospital, it's red, so don't go by the orange tip. But that's exactly what you hear from nurses. Oh, it's always blue, and today it was orange. So I didn't read it. Read it until you are retired. Okay? I don't care if you've had a blue label for 10 years. The next month, it may be orange. So read the label. And in all of those cases, the nurses didn't read the label. In that case in Colorado, where the child died because the dose was calculated to be too large to give IM, so they gave it IV. Can you change the route? No. You're not a nurse practitioner. You didn't prescribe it. You have to adhere to what's written. But most med errors occur because the patient's ID is not checked. Whenever you give any med at all, the MAR has to match the name on the ID band. Do not give anything if they don't have an ID band. Make one, have the secretary give you one to put on that patient. But for goodness sakes, don't make assumptions. It has always been whatever color, and now they change the label. 5 rights don't change. Evaluation of care. So failure to monitor your patient. Failure to identify what it is you're monitoring, not recognizing deficits. Failure to obtain medical assistance when the patient's status is changed. And failure to challenge an appropriate order cause patient injury. So in the case of those nurses in Colorado, the doctor had written the wrong order. The pharmacy didn't catch it, sent that 10 times the dose. The nurses actually checked with pharmacy, and the pharmacist said, yes, that is correct. But guess who lost their jobs and were charged with involuntary manslaughter? The nurses. Who gave it? It doesn't matter if the order was wrong. You need to challenge if something is wrong, and don't give it. Sometimes the nurse will say to us, oh, you know, the doctor just ordered whatever, and it's stat. Will you give it? We check the MAR, it's not there. So I always tell the nurse, you'll have to give it. You took the verbal order, it's not on there yet. We can't give anything unless it's actually on the order. And sometimes something has changed, they know about it, the physician told them at the bedside, and then they'll tell the student, oh, you know, don't give that DHO 0.25, we're going to double the dose, or whatever. Don't follow those verbal orders, see it in writing. Every now and then we have to give a drug that is maybe 5 or 10 times what our book says is the usual dose for patients. And that does happen because patients have been taking the drug for a long time. It's often some sort of pain med, and they're getting some humongous dose. I will not let students give that. You are still a student. And even though it's ordered and the nurses will say we've been giving it, you will not give that because you've checked the dose and it doesn't fall into that range of safe dose. Does that make sense? So just because the nurse says this is what we've been giving, the record indicates that that's what the patient's been getting, don't give it as a student. It's not in your drug book labeled as an appropriate safe dose. The other thing in terms of evaluation of care, if you think your patient has made a turn for the worse and you assess deficits, what do many hospitals have to help you out? The rapid response team. Did you read about that in your book? Tell me what it says in your book. What about the rapid response team? Who do you call? What do you call them for? Sudden changes. Blood pressure changes. What else? Neuro changes, LOC changes. Okay. So they will intervene when a patient's beginning to decline. Usually it's a critical care nurse. The critical care nurse usually comes and assesses the patient first. They may have physicians on that rapid response team as well if they need immediate assistance. So if your patient status changes, then you can call the rapid response team. No harm done. They will quickly assess whether the patient's going into shock or if they're getting septic, or look at the labs really quick and make a recommendation to the physician. Here's a statistic that you should just keep in mind. Clinical condition changes in status occur in most patients 48 hours before a code is ever called. So these rapid response teams have eliminated the code calls by 50 to 75% in most hospitals because the nurse who's caring for the patient detects a change in status. They call the rapid response team, intervene at that point in time, and the patient never has that cardiac arrest or respiratory arrest. So what would prompt you to call? Change in vital signs, but what kind would you call for? Okay, respiratory what?
Patients be, short of breath, maybe?
Okay, so shortness of breath.
Right after surgery,
Okay. What can
Blood
you,
pressure's really high or really low?
okay, blood pressure's really high or really low, and you've looked at the trending, and it hasn't been that low before. So you have hypotension, hypertension, blood pressure's 200 or 250 over 150, for example. How about the heart? What would you call for? Tachycardia and bradycardia. What's tachycardia? How fast? Greater than 100. Bradycardia? Less than 60. Okay, and somebody already mentioned those LOC changes. The patient was awake and alert, and now they're not even talking to you. They're becoming unresponsive. That would certainly warrant you calling that rapid response team. So, does the patient benefit from that by having you call the rapid response team?
Yes.
Do you also call the physician?
Yes.
Yes. Depends on the hospital. In some places, you don't call the physician until the rapid response team has evaluated the patient. It just depends on what kind of a unit you work on. So in many cases, you would, in fact, call the physician and that you call the rapid response team. But they can probably prevent, in many cases, that patient from going into respiratory cardiac arrest. Floating. What is floating? Yeah, the hospital has a duty to provide care to all patients that enter their door. People call in sick. So if you were assigned to the 4th floor and now the 4th floor is short a nurse, they may send a nurse from the 5th floor because their census is low to accommodate the needs of the patients on the 4th floor. So if you are floating from one floor to another, what is your responsibility? To do what?
To find out what the protocol is.
To find out what the standard is, what the protocol is on the unit, absolutely. What's the frequency of vital signs here? What is your protocol for assessments? What's the frequency of assessments? Where's your crash cart? Okay, what else?
Held to the same standard.
Yes. You are held to the same standard of care that the nurses on that unit need to provide to those patients. And for that reason, every hospital, I think, probably has a float policy where you have to go to a different unit. But if you work on a med-surg unit, they will maybe float you to another med-surg unit, but they won't send you to the critical care unit. And if you're in a critical care unit and there are 4 critical care units in the hospital or whatever number, you may float between those units. But they try not to send you to an area where you're not competent. If you're not competent to do something, don't go by the seat of your pants. Well, I think I can figure out how this works, and let me just see if I can finagle this. Don't do that. There was, last year, there was a nurse who was floated, I'm trying to think what it was. A hospital was on strike, and they sent strike breakers, or not strike breakers, they sent nurses to replace the nurses who were striking. And then this particular nurse ended up on a unit that she was not familiar with. And I think we already told you this when we talked about the tube feedings. The nurse connected the tube feeding tubing with tube feeding flowing through it, didn't quite fit the connector for the IV, somehow finagled it and attached it, and the tube feeding was perfusing, dripping into the IV. So do your veins and blood vessels like nutrition in the form of tube feeding in your system, your vascular system? No. So what do you think happened last year? The patient quickly died. So if you have to float, you don't know how something works, ask. Don't do it if you're not sure. Okay, we already talked about delegation, and then what about students? How about you?
Same responsibility as an RN.
The same, you have to provide care to the exact same standard that the RN provides. Don't ever forget that. You can't just sort of kind of put that Foley in sort of sterile, because there is no such thing, right? Sort of, well, kind of close, maybe not, maybe I contaminated a little bit. It's not acceptable. So whatever you do is done to the standard that an RN would. So don't accept an assignment beyond your preparation, okay? if you haven't learned IV therapy and you're working with a nurse and the nurse says, oh, you know, when that pump alarms, we just push this button so that the next IV will start to run, or whatever they ask you to do, you haven't learned IV therapy. Don't participate in pushing buttons for pumps and drugs that you don't know. Okay, in terms of environmental hazards, we're going to look at some of these in hospitals. As far as accidents are concerned, what kind of accidents do a lot of young children fall victim to? Drowning and burns, scalding. How about young adults? Motor vehicle accidents, sports injuries, skateboards, all of those things that have a risk. Most sports do have some sort of risk. How about older adults? They fall. And the long-term care facility where I was towards the end, there were just an amazing number of people who had fallen, a large number, and they had fractured their hips or broke their pelvis or whatever. The majority, I think, of those patients were there because they had fallen. If you talk to some of those patients, they are just so exasperated that they fell, because many of them realized, because they were in their 90s, that they may never walk again. Because if they sit too long, or they don't get mobilized quickly, or therapy isn't done rigidly every day as ordered, frequently in long-term care they skip it. The patient says, oh no, not now, I just, I'm 4 days post-op, and then they don't come back. So that's why people who are in long-term care, they need to or rehab, they need a family member who does what? Advocates for them, or a nurse like you who advocates for them. We're going to talk about all of these other things: the fire, the scalds and burns, the poisoning, electric shock, and the falls. Yes.
What's like the proper response? Because I had like a patient that he was in his 50s, and he was all sad at the fact that he fell and broke his hip. And he kept asking me, like, oh, what do you think my outcome is going to be? Like, am I going to walk again? And I didn't really know what to say.
It's a huge concern. So therapeutically, as far as therapeutic communication, what could you have said?
I was kind of, I don't know. I didn't know what to say because I didn't want to lead him on. And
Right.
sit him
So
on.
if the patient says, will I ever walk again? The patient's in his 50s, and he expresses that concern. What is a therapeutic response?
How does that make you feel?
No. What's the therapeutic response?
Let's talk to your doctor.
That means they're asking you, and so you're shoving it off on someone else.
Or when do you think that?
Yes. Tell me why you're concerned about never walking again. What else could you say? Anything else? How you can ask them about, are they concerned about the success or the outcome of the therapy? What is it about the PT that they're getting that makes them believe that they're not going to walk again?
Because he had vertigo, and that's what he wouldn't let go. He's like, I know I'm going to fall again. So,
Oh.
like, he was like normal. He was a normal guy. Like, it was just the fact that he fell. That was
So maybe they need to treat the vertigo. Had he not had vertigo, he might not have fallen. Were they treating that?
Yeah.
Okay. So maybe then you could say, well, it was due to your vertigo. We're treating your vertigo, and if you're no longer dizzy, your risk of falling is greatly diminished. You need to all start thinking about what the patient tells you, and then not interject your own story, but put it back on the patient. So if the patient expresses that sort of concern, then you need to say, well, tell me a little bit more. Why do you think you'll never walk again? You're 55 years old, and tell me why you're concerned about that. Sometimes that happens. They don't walk again. But mostly that's with the older, the 70s, 80s, and 90s. Okay, so a little bit about, we're going to go over most of these. Every hospital you go to has a fire alarm system. Every hospital you go to, you will have to, during orientation, learn about their code red, okay, and what to do. They will have, I think, monthly code red drills And when they have a code red drill, as a student or as a staff person, you need to participate. So if they announce that this is a code red drill, what do you need to do?
Close all the doors.
Close all the patient doors. Why do we close all the doors? To contain the fire. Activate the alarm. You need to know when you first get to a new facility where that fire alarm is and how to make it work. Not only in hospitals you have to pull the fire alarm, but you have to get on the phone, call a code red, and identify the location. So there are two notifications that you have to do. Call the code red in the hospital system, pull the fire alarm so the fire trucks start rolling. Once the fire trucks get there, you can't say, oh, we fixed it. They have to actually check to see what the problem was. Confine the fire, so we close all the doors. If the fire's in the patient's room, you need to evacuate the patient from the room, shut the door. Once the doors are shut, if there's a real fire, nobody can be a looky-loo and have a look-see. Okay? Once the door's closed, only the fire department can open the door. Okay. And then extinguish the fire if it is small. You need to know where your fire extinguishers are. But if you're not properly trained on how to work a fire extinguisher, just keep the door closed. If the fire is small, we were in a facility last year and the patient's bed, the motor overheated and the bed caught on fire with the patient in it. A lot of those, like those low air loss beds, those beds, the therapeutic beds that they have, it just overheated. So we needed to quickly get the patient out, transfer him to another bed. When I first got into nursing, it was very, very common for people smoking, but they got the smoke in bed. Now you think about it, it's like, what were we thinking? But out of my 56 patients, I'll bet you 50 smoked. Not only did the patient smoke, but the family members at the bedside smoked cigarettes as well. So if you walk down the hall, you can see this haze of cigarette smoke. Nurses have never had large nursing break rooms, lounges. That's where they had this little tiny room. And for a report in the afternoon, because I worked the PM shift, I would open the door and it was like, is there anybody in here? Because I can't see. The cigarette smoke was horrendous on the nursing units. Patients would get something for pain, but they were smoking and the cigarette would fall out of their hands and they would throw that lit cigarette, into the bed or into the wastebasket and it would catch on fire. So we had many small fires that we would just take the water pitcher and put it out. But it was really, when you think about it, quite a dangerous situation for patients. I can't tell you how many beds the sheets and linens caught on fire. So, fire, you need to remember race, the order of race. Okay? So, rescue, activate the alarm, confine the fire, and extinguish. You need to know that order. If you have to use a fire extinguisher, you have to remember PASS. So that stands for pull the pin, aim low, so you aim that nozzle at the base of the fire, not into the top of the fire, at the base of the fire. The S is squeeze the lever below the handle, and then sweep from side to side at the base of the fire. So that's PASS. Okay, electrical safety, real important in hospitals. Most hospitals have a standard that requires that everything that is connected, as far as the patient is concerned, has a 3-prong plug. So you can't take the ground part of the plug out to make something fit. The 3-prong plug is required for everything that's attached to the patient. An electrical shock is still a cause of injury to patients. Sometimes patients need to be moved into bed, they're going somewhere or they're changing rooms, and the bed's getting pulled away, the bed is still plugged in, and I can't tell you how frequently I start paying attention. They'll just yank it out of the wall instead of pulling it by the plug. That could interrupt the wires inside the cord and may cause electrical shock to a patient. I had a patient once every time I touched the metal side rail, I got this little tiny shock. The whole bed there was something, there's electrical leakage somewhere, frayed wires, and the whole bed, you could feel little tiny little electric shocks. So if you ever feel that, and the patient had a pacemaker, so I was concerned, one of those temporary pacemakers, got the patient quickly out of the bed. And usually they don't allow extension cords. And if you have a piece of defective equipment, then you need to lock it out and tag it out. They have forms, tags that you hang on, lock out, tag it out. Write on there what the problem is so that Biomed or whoever fixes it has at least a heads up as to what is wrong with the piece of equipment. It's not uncommon, it happened to me a number of times. You need an IV pump, and you go to the clean utility, you pick up an IV pump, and you're playing with it, and you're trying to get it programmed, and half an hour later you decide this thing isn't working right. And so you just stop the whole process, look for another pump. Somebody then will say, you say, oh, you know, I've worked every which way, can't get this thing to work. Oh yeah, I tried that too. Well, what'd you do with it? I put it back in the clean utility room. Didn't lock it out, tag it out. Would have saved me or whoever has the defective pump, would have saved them 30 minutes of trying to make it work. So if something doesn't work, tag it out and write on there what's wrong with it. I think all of you are familiar with fall precautions, right? The yellow magnet, the yellow ID band, the non-skid slippers with the non-skid stuff on top and the bottom, because for some reason sometimes patients end up with the non-skid on top of the foot instead of on the walking surface. What are some of those risk factors for falls? Age is certainly a big one. If patients have balance problems, like you said, the patient had the what do you call it? The vertigo. Certainly would affect their balance. So lots of things, risk factors. Patients who can't move on their own, if they're really weak, are at risk for falls. Musculoskeletal sort of diseases or injuries that they may have had make them at risk for falls. Clutter in the room, make sure that the rooms are always neat and that the path where they need to walk is clear. So as far as back to the other slide, you remember all of those things that are risk for falls? Is there anything that I've forgotten? Why is hypotension at risk for falls? Yeah, they get out of bed too quickly and they develop what? Orthostatic hypotension, okay. I think I've pretty well covered all of that. Is there anything? Urinary frequency is on there, so if they have to get out of bed, turn the night light on at night, keep the bathroom light on if they're going to actually get out of bed. If you've medicated a patient and it's a medication that will affect their level of consciousness, put the side rails up. Document that you put the side rails up. Other environmental hazards, excessive noise may cause hearing damage, but we are not. Sometimes you get pretty doggone noisy in hospitals, but not noisy enough to cause hearing damage. Suffocation and choking. What did patients, maybe a decade ago, what caused them to suffocate? The what?
The plastic bag.
Plastic bags? No, not so much. Restraints. Yeah. And following the large number of patients who died because they suffocated on restraints, then the federal government stepped in. We now have federal guidelines that require all of that monitoring and those orders they have to have renewed every day. That was based on a large number of patients dying because of restraints. They were applied improperly, they were not put on correctly, all kinds of things. So now with restraints, you have all kinds of monitoring you have to do. Procedure-related accidents, like what? Can you think of anything that would be procedure-related?
Amputate wrong limb.
Yeah.
Documented.
Absolutely. Happens all the time. Patient has to have an amputation, a right leg amputation, and they amputate the left. They have a diseased right kidney and they remove the left. They're supposed to have brain surgery on the right and they do the surgery on the left.
They leave stuff inside.
They leave things inside. Yeah.
They get a pressure ulcer from laying too long.
They develop a pressure ulcer from laying in the same position for a prolonged period of time while they have the surgery.
That happened to a girlfriend of mine. She was having some kind of laparoscopic something or other. They left a whole bunch of gauze in there.
Yes. Instruments left behind, sponges left behind, equipment that malfunctions and causes burns. I think we've hit on a number of them. Happens more frequently than you think, procedure-related accidents. Equipment that overheats. I think you get the picture, right? And then how about radiation? Radiation safety. You'll see a sign on the door, right? First of all, the next slide is more about the portable x-rays is the first one. When they're being obtained, keep a distance of 6 feet. Sometimes they will ask you to hold the patient in a certain position because they can't cooperate and do that for themselves. If that's the case, the portable x-ray equipment usually has a lead apron hanging on it. You should ask for it and put it on. Especially if you have to stand closer than 6 feet. They'll say x-ray. When you hear that being said, you need to step out of the room to keep yourself safe. You don't want to have 10 x-rays a day on different patients because you didn't leave the room. Patients who are a source of potential radiation contamination require precautions. You have to put a sign on the door. They're always in a private room. And remember time and distance. The shorter the time and the greater the distance, the safer you stay. Some patients have what we call sealed or solid implants. You'll care for them. If they have a sealed or solid implant, for example, for prostate cancer, or, oh gosh, I can't think of any other example off the top of my head, cervical cancer, they'll have these sealed implants in place. The patient will be in a private room. You have to remember that the patient emits radiation while the implant is in place, but any body fluids, stool, urine, whatever, is not radioactive. You can actually flush that down the toilet. But the patient is radioactive. They emit radiation. So you're going to go into the room, do as much as you can with a lead apron on. Sometimes you'll see family members sitting quietly at the bedside. And it's kind of like those family members who sit at the bedside in an isolation room. It's your job to remind them to remember the time and distance, that they should stay no more than probably a few minutes, at the most probably 30 minutes. But they'll sit there for hours and nobody tells them anything. So keep your patients, keep yourself safe, but keep the family members safe too. So for those,
Tell them and they don't care what then.
then you need to document in the medical record. Patients' families at the bedside, discourage them from staying so long, explain time and distance. They insisted on staying. That's what I would do. Once you've informed them and they're adults and they can comprehend your instructions, you can't really physically boot them out of the room. So these patients are in a private room, usually at the end of the hall. They'll have a radioactive material sign on the door. Pregnant women or anyone under the age of 16 should not enter the room, should not care for the patient. For safety reasons, visitors have a max of 30 minutes a day, okay, at a distance of 6 feet. But where are these patients' families often sitting? Right next to the bed, and they're holding their hand. Save all dressings and bed linens until the radioactive source is removed. And they'll have linen hampers in the bathroom, and you just collect it all and don't take it out. If the radioactive source is dislodged, you either need to call the, what's the name, not biomed, radiation safety I think is what the person is called, the radiation safety officer, needs to come in and take care of any sort of implant, a source that is dislodged. Every now and then in the room you'll find a box, a lead-lined box with forceps in it. So if you were to find that sealed source of radiation in the bed, if it has fallen out, don't touch it with your bare hands. Grab it with those forceps, put it in that lead-lined box, and then call the radiation safety officer. If that's not the case, they will take care of it, so don't touch it. If you were working all the time with these patients who have sealed implants, some hospitals will give you a dosimeter badge, the kind of badges that they have in radiation, in radiology, but they have found that nurses don't get enough radiation in the course of their work to really warrant the monitoring with the badge. So you don't need that. Many of your patients will go to MRI. It stands for magnetic resonance imaging. It's real important that you remember certain safety factors that you need to implement for your patient. Number one is that there's a special checkoff sheet that you have to complete before the patient goes to MRI. If they have certain sort of implants, metal implants, they're not candidates for an MRI. So just go down the checklist, and if there are any yeses, you need to let the MRI people know. IV pumps or monitoring devices cannot be brought into the MRI room. They have these little portholes, and they'll sneak the tubing through the portholes, but they won't bring the actual equipment in. All equipment, including the gurneys that the patient's on, have to be compatible. A couple of years ago, again, it was someone who was floated to the unit. You probably know all these stories. It was just one of those comedy of errors. I shouldn't say comedy. What's the word I'm looking for? Tragedy of errors. The float nurse didn't know about the right gurney, and then the patient was sent in on a gurney that was not compatible because MRI is a gigantic magnet. And so the wrong gurney, and the patient had an O2 tank strapped to the gurney. The O2 tank got airborne, slammed into the patient's head, and the patient died. Where was it? It was a pediatric patient. I don't know what kind of patient it was. I just heard that they died because the O2 tank got airborne and it was inadvertently taken in. Sometimes if you walk by, if you know there's an MRI machine inside, like on the other side of the wall, every now and then I'll walk by and my stethoscope will pull away from my uniform. That's how strong that magnet is. So be aware about the safety of MRI. If you do go to observe a patient, you get to rotate through in some of the hospitals where we go. You go to MRI and CT and interventional radiology just to see what patients go through. Don't have anything in your pocket like your driver's license, credit card, because it'll erase everything. It'll stop your watch. You don't want to take anything in. Take it all off. Yeah, it's probably best for you as a student not to go inside, just watch through the window.
Well,
It's what?
like for our job, we have to.
Oh, for your job.
Everything and then.
Yeah. So keep in mind the MRI machine, the magnet is always on. It is never turned off. Yes.
Pacemakers?
Can they go in? No. No. It says patient with a pacemaker, implanted mechanical device, cannot be
I
scanned.
wasn't there yet.
Okay.
Good setup.
Okay. The next is, you already know about all of this, right? Hygienic care. You know what AM care is? Morning care. What does that consist of?
Shower.
Okay. Oral hygiene, washing your hands and face, right? Mouth care should be done every shift. Ideally, it's not generally done every shift. How about PM care? We don't do much of that anymore. Wash your hands and face, fluff up the pillow, put a clean, fresh pillowcase on if it looks all, you know how sometimes it looks like it's been It's just too tired and wrinkled to be used. How about HS care? Before sleep, so ask the patient about bathroom needs, toileting needs, brush their teeth, wash their hands and face. Speaking of washing hands, if you're taking care of a patient who uses a urinal or a bedpan, every time you come to the room and you see that the urinal has been used, you take some of the alcohol gel, put it on a paper towel, and hand it to the patient. Normally, we wash our hands after using the restroom. Those poor patients are stuck in the bed, and so then the next thing you know, the meal tray comes and they still haven't washed their hands. So if you see urine in a urinal sitting at the bedside, have the courtesy to give them some hand gel and say, I noticed you use the urinal, you can wash your hands, here you go. PRN is just as needed. If they're incontinent, need to be cleaned up. If they've had vomiting, clean them up. If something came disconnected and drained into the bed, that would be PRN care. And how about skin care? How do we keep the skin intact? Keep it clean and dry. What else? Don't what?
Rotate the patient.
Rotate the patient. Turn them at least every 2 hours. Some patients need to be turned every hour if they have huge decubitus ulcers. They can't stay on one site more than 2 hours. What else? You have to be careful when you move them up in bed. What's that called if you don't use a draw sheet? What happens to the skin? Shear. One layer of skin stays against the bone and the other layer starts to shift. So it shears the skin and causes tremendous damage to the tissue. How do we keep their skin from drying out? Lotion. Put some lotion on. Okay, and then those pressure ulcers. Look for those areas, keep them turned. Okay, you know all about bathing, right? How many of you have not done a bed bath? Oh, a couple of you still. The majority has given a bed bath. That's good. A self-help bath, if they have at least one good arm, they can do their own peri-care. So don't let them talk you into that they need help if they have one good hand, okay? If they have a Foley catheter, you need to look and wash it and do Foley catheter care. Wash with soap and water. But every now and then, we have some really nice, sweet nursing students who get roped into doing complete peri-care as someone who is totally capable. So if they have one good hand, it doesn't matter if it's not their dominant hand, and there's no IV on it, no restriction, have them do their own peri-care. Partial bath, tub bath, we don't do much in the way of tub baths. Yes? Oh. As a matter of fact, the tub rooms are usually full of supplies and equipment. Showers, yes. Patients do get the shower in many cases. Sometimes patients, you need a physician's order for a whirlpool bath, especially if they've had burns. Next semester, patients will get sitz baths to gently flush the perineum with warm water. And sometimes we have the patients give themselves a betadine shower. You hand them the betadine. Make sure that you hand them the betadine that's the foaming kind of stuff for a bath. It's not the betadine that you would use for a wound. Okay? So read the label. Okay, we already know about medical asepsis, right? What does medical asepsis do? It confines microorganisms to a specific area. So clean, absence of most microorganisms, and dirty soil or contaminated. So linen, mopping the floor, that's considered dirty or soiled stuff that goes to the soiled utility room. Surgical asepsis is sterile technique for whatever requires sterile technique. The suctioning, the trachea that you already learned, keeps the area free from all microorganisms, so it keeps it sterile. It's required for all invasive procedures, IV therapy, Foley catheterization, suctioning, wound care, if it's a sterile dressing change. Okay. A little bit about nosocomial infections. Infections that are nosocomial are hospital acquired. Okay? So anything nosocomial is hospital acquired. And nosocomial infections cause tremendous amounts of, well, first of all, it's very expensive, causes harm to the patient, and some of you have been on units where maybe all but one patient was in isolation. How do you think that happened?
No hand wash.
No hand washing, or inadequate hand washing, or
The movement of equipment from one room to the other.
Yes.
They did a lot.
yes, and you think, oh my gosh, it's no wonder 38 out of 40 patients are in isolation.
Were you bringing it up because I know there was this lady, she was a patient, she was a nurse herself,
Uh-huh.
and like she was complaining about the IV poles. I mean, she brought up a good point. She said that she was purposely observing, and like she said that she would see when like they would hand them down to the patients, and they never washed those. Also I'm not sure what you call them, the ones when we would go bathe them, like actually shower them, the seats that you
The
put
shower
them in.
chair.
I mean, it's true. I never saw the CNAs ever wipe them down because I saw when I cleaned my patient, she just took it and sat the other patient down.
Yes. Yeah.
I mean, it didn't hit me obviously until she brought it up.
Infection control starts with the individual. If one doesn't wipe things down and the next nurse doesn't wipe things down, then you may be the recipient of that C. diff on that shower chair, or the C. diff that is readily on that IV pole that somebody has touched in the patient's room. And so there's no surprise that 90% of some of those patients, every bed is in isolation for the most part on those units. And then you actually observe that lack of infection control. And many, many patients die. They become septic. It's not without great risk to the patient. So hand washing is really important. Transmission through contaminated hands of the organism on environmental surfaces is probably the most common way things get transmitted. For C. diff, remember if the patient's in isolation for C. diff, that you must wash your hands with soap and water, because the C. diff produces a spore, and you don't kill it with alcohol, but mechanically scrubbing your hands is what, and the flushing of the water is what washes it off of your hands. So very important that you not even touch the pump alcohol gel, because then that pump mechanism is immediately contaminated as well. As far as environmental controls, the cleaning, they have found that with C. diff, that the organism stays on the surfaces in the room that the patient has been in contact with, the overbed table, the side rails, the bed, for months, unless it is properly decontaminated. Months. So the same with you. If you don't wash the bottom of your shoes off with the Clorox wipe, or you take them in your house, then you've got that stuff kind of spreading around without you really being aware of all the surfaces that become contaminated. Sterile technique needs to be used when it is called for, and then we need to identify the patients who are at risk, but for the most part, everyone in a hospital is at risk. Everyone has an altered immune system due to age or due to disease. Okay? So strict adherence to clean hand policies alone, just hand washing, could prevent the deaths of 20,000 patients, just the hand washing. That is pretty huge. There are 130,000 annual deaths linked to hospital-acquired infections. So that's not just the infections, those are the patients who die as a result of the infections. That's a lot of patients, and certainly we don't want to be the recipient of that infection, nor do we want to contribute other patients to that risk. Okay, this is from your book, and I think it's in I think it's at Iggy on page 446, and it's in Kosher on page 635. You need to be familiar with this. What's this called? The chain of infection. Review it, be familiar with it. So with the chain of infection, the number one thing is the etiologic agent. What's the etiologic agent? The actual organism that causes the infection. So name some. Bacteria, fungi, viruses. That would be the etiologic agent causing the infection, right? The next one is the reservoir, the source. So the source could be, we just talked about that, the IV pole, the vital sign equipment, the beds, medical equipment. So the reservoir is where it resides, the source of the infectious agent. Then the third is a portal of exit from the reservoir. So how does it get out? The GI tract, if you have C. diff, right? Because the patients have diarrhea. MRSA and the nares, the portal of exit is the nares, the respiratory system. It could be the skin that is the source of the infection. The genitourinary tract. If you have MRSA in your urine, for example. The mode of transmission is, so if you have a patient who has C. diff, how does that transmit it to the next patient? By you. On your hands, right? So if you didn't wash your hands well, whatever you touch becomes contaminated. So the mode of transmission could be your contaminated stethoscope. Every time you take your stethoscope to a different patient, find one of those canister of wipes and wipe the whole thing down. It's not sufficient for just wiping down just the part that you're going to place on the patient. The tubing, everything needs to be wiped down. They did some studies a couple of years ago in a critical care unit. They couldn't figure out why people had sternal infections post open heart surgery. And guess what they found was the cause. Contaminated stethoscopes going from one patient to the next. So make sure that you're not part of that mode of transmission. You can also ingest, right? What could you ingest to cause, like the mode of transmission? Like food poisoning, right? Okay. Could be airborne, could be droplet, could be contact type of isolation patients. And then the next one is the portal of entry to the susceptible host. Okay, so how does it get into those patients who get infected?
A lot of times they're compromised or have open wounds.
They already have, they're already at risk. They're very susceptible. They don't have intact skin. Their immune system is not intact. So they end up with a wound infection. They end up with respiratory infection, whatever it may be. What makes a host susceptible? The diminished immune system, right? Open wounds and not intact skin. Anything else? Not having been vaccinated. I'm sorry? Older people, because their immune system is greatly diminished in terms of its effectiveness. Malnutrition, does that contribute to, okay? And that brings us back to the etiologic age. So you got to break that chain of infection wherever you can so that it doesn't make its rounds. Okay, I think we've pretty much talked about this. Infection control, the hand washing. At the long-term care facility where I started, they had this little video where they showed how to hand wash. You know, and so what they suggested was that you actually manually just clean your thumb, that you clean your tips of your fingers by putting them in the soapy or whatever you have, the soap on your hands, and clean them in the palm of your other hand. What else? Really good scrubbing between your fingers, but they had a great video, but it was just, yes, the thumb. But it makes you aware of how important it is to just get all areas. So soap and water have to be used when your hands are visibly soiled, or when the patient has C. diff, diarrhea. Before eating or drinking, I would hope so, that before you have your lunch, that you will wash your hands. You should all know that the OSHA Safety requirements do not allow you to eat or drink anything in a patient care area. Can't chew gum, you can't have your cup of coffee next to the computer, you can't have anything in the patient care area. And hopefully you'll wash your hands after using the bathroom as well. We all know about hand hygiene? Yes? Okay. As far as standard precautions, I think we're pretty well drilled this already into you, correct? Standard precautions, who decides when to use them? You do. You determine what kind of exposure you may be anticipating, and then you would implement the gown, the gloves, the mask, and the eye protection as needed. If you have biohazardous waste that you need to get rid of, what would be considered biohazardous waste, and what needs to be red bagged? Body fluid. If you were to step on saturated dressings and the blood was squeezed out, that is biohazardous, needs to go into a red bag. If you have gauze from a dressing that is not totally dripping with body fluids, blood, or whatever, you can throw it in the trash. Okay? And you red bag it as you walk it across the hallway and find a red bag in the soil utility room. You red bag it from the patient's room.
Double bag.
And it has to be double bagged. So in that case, if you're carrying a red bag, can you have gloves on? You should have gloves on. You may never walk in the hallway with gloves, except if it's obvious that you're carrying contaminated waste to the utility room. Dedicated equipment, if you have a patient in isolation, the blood pressure equipment, the stethoscope, should all be dedicated to that patient's room. You shouldn't have to use your own stethoscope. Shouldn't. The stethoscopes they give you that are disposable, you throw out when the patient's discharged, are just horrible. You can hardly hear anything. But if you do use your own, you need to take those Clorox wipes and wipe down absolutely everything. So wash your hands, put on clean gloves, take your stethoscope. If that canister with wipes is not in the patient's room, then you need to walk it to where it is and then clean everything off, wash your hands, and you can reuse your stethoscope. Okay. Transmission-based precautions, I think we've pretty well covered that. Okay. Airborne. Okay, so airborne tiny droplets for TB, chickenpox, measles, and smallpox. You have to have an N95 respirator mask, and you have to be fit tested, so we don't go into airborne rooms. Droplet are large particles, and these patients, usually the droplet is the spitting distance. If you come not closer than 6 feet to the patient, you can actually step in, talk to the patient, and not have to put on anything. Okay, but generally the rule is you put on the mask if it's a droplet thing, because chances are the patient called you for something and you need to get close to the bedside. We already talked about the contact. The droplet also includes diphtheria and meningitis. Okay. The food and waterborne transmission, the vector insects, ticks, and mites. Okay. A little bit more information about methicillin-resistant Staph aureus, MRSA. How many of you had patients with MRSA? So a lot of you did. The patient can be either have an active infection, which means that they have symptoms. Okay, it's usually a skin infection. You'll see the skin lesions with MRSA. It looks like a sore. Sometimes they think it's a bug bite. That's how it started. And then they culture it and it turns out to be MRSA. A carrier could be any of us. We've cared for these patients, and a carrier means you don't have symptoms, but you still have MRSA living on your skin or in your nose. Okay? So carrier or colonization is the same thing. You may see different words. So how do you prevent cross-contamination to your patient? You need to wash your hands because it's contact. The C. diff It's caused by an anaerobic spore-forming gram-positive bacilli, and we know that these patients often have liquid stools. Some of them have the rectal tubes in place to collect the liquid stool. Who had that patient with the rectal tube? Oh, two of you did. Just liquid watery stool, and so they'll drain it into like a Foley bag. It's treated with vancomycin or Flagyl, and you need to wash with soap and water only, no alcohol. And the C. diff persists on surfaces for months. It's just there. What else? I think that was it for C. diff and MRSA. How long does a person stay in isolation for MRSA or VRE or any of those things, in contact isolation? Until you have 3 negative cultures, and that's when you take them out of isolation. We gave you a handout in 101L that had those columns. Remember the handout? The isolation protocols? Grab that out of your notes and review it. You should know that. Okay? And you should know if the patient's room door can be open or if it should be closed, and what you need to wear in order to keep yourself safe. Okay, so the next one is removing personal protective equipment. If you're in the patient's room and you have a gown and gloves and things on, you need to take the gloves off, turn them inside out as you take them off, and then wash your hands. The next thing you would take off after you washed your hands is remove your mask, if you're wearing a mask. If you're in an airborne room, leave the mask on. Don't take the mask off till you leave the room. Otherwise, the mask is second, and then you take off the gown. You can probably just tear it in most cases. Turn the gown inside out as you take it off, and then you wash your hands again. If it's an airborne precaution room, you would at that point take the mask off. Okay. On the N95 respirator mask, you can probably wear it the whole shift. You don't throw it out each time you go into the patient's room. As far as healthcare workers are concerned, the major problem we have is needle stick spill. Needle stick still cause major heartache for staff. So I mentioned earlier, if you're in a room where a code occurred and they have all these treatment trays and they've had sharps on them, very, very carefully look to see where they are. Very carefully grab one at a time and put it in the sharps container. And every now and then, somebody from housekeeping gets stuck with a needle because that tray was thrown in the trash. The liners are plastic, and then as they remove it, they get stuck with a needle. If you have a needle stick, then squeeze the puncture site. Don't be embarrassed. You need to just immediately take some action. Make it bleed. So don't try to stop the bleeding, and don't suck on it, on your bleeding, whatever you have. Wash it immediately with soap and water, and then every hospital has a protocol for needle sticks that will be followed. You will not necessarily find out whose needle that was if the patient had hepatitis A, B, C, or has HIV. The patient who, if it is known that you stuck yourself with a particular needle from a particular patient, that patient does not have an obligation to be tested for HIV. So you don't have a right to ask that patient to be tested, so you may never know. So what do? What do these protocols have you do? You get a baseline at the time of the needle stick.
I got my book myself.
Oh, okay. You get a tetanus shot, and what else?
And then just like HIV test.
Yes.
Like
At the time of the needle
Right,
stick,
and then
3 months,
later, and then
6 months, and a year. Because it takes time for, if you were contaminated with HIV, for that to convert, to get enough virus in your system for it to be available to be tested through the lab.
Something we'll ask the patient, because my dentist stuck himself.
Yeah?
But the thing is, he called and asked if I would.
Yes.
It was voluntary, but yeah.
Yes. And if the patient says no, there's no way they have to abide by your request to be tested for HIV. And that's why we say just assume everyone is HIV and hepatitis A, B, C positive and use universal or standard precautions. So the patient does not have to submit to testing. And most of the time when you stick yourself with a needle, you don't know whose needle it was anyways. When you're discarding needles into the sharps container, if you see any sort of, sometimes needles are poking out upside down, don't even come close to it. Have, lock it up, have housekeeping come and change it out to a new sharps container. Most sharps containers need to be changed out when they're 3/4 full, not at the full level. Okay. As far as personal protective equipment, you are responsible for yourself. So, as far as the major occupational hazards, HIV, there is no vaccine, but most of the drugs that are available now keep patients pretty safe for a long, long time to where they can't even detect the presence of the virus. It's still very bad news if you do become positive. There's no hepatitis B vaccine. There is hepatitis B vaccine available, and there's no vaccine for hepatitis C. Hepatitis B and C are much more readily transmitted than HIV. So the risk of getting hepatitis is much, much greater if you have a blood exposure. So you need to immediately report it, and then we will certainly go through that whole protocol. As far as TB is concerned, if you think you were exposed to TB, what do they do? Annually, you have to be tested, right? You get a letter that you may have been exposed, and then what?
Then you have to go and get your test and go back in 2 weeks or in a week and get another test.
Okay, so they're doing that double testing a week apart.
You get them every couple of months.
You get them every couple of months. So what test is definitive for TB? The chest x-ray? No, not necessarily. The TB test? No, that just means you've been exposed. But what is definitive for TB? The sputum. A culture and sensitivity of the sputum is definitive for TB. Usually it takes, those cultures take a while. May take 1 to 3 weeks. But they have a new test now. I'm not sure if they're using it, but you get a very quick response to the culture and sensitivity, much quicker than 1 to 3 weeks. Sometimes they do a gram stain. The gram stain is not specific for TB, but it gives you sort of an idea if perhaps you've been exposed to TB. But the acid-fast bacillus is not specific for TB. Culture and sensitivity is definitive. And every hospital has TB protocols as well, as far as exposure. As we just heard, you have to be tested and then retested. And okay, restraints. We all know about restraints. Where do you tie them? To the bed frame. If they still have the old style, you must tie them so that with one hand you can release them. You may never tie a knot in them. Most of them now have the clips. Very easy to just release the clip and to clip it back to the bed frame. You all know that we need to do everything we can to avoid restraints, right? And monitoring is at least every hour NPRN for med-surg type of restraints. Every 2 hours you have to release it, offer food and fluids, and toileting opportunities. And do CSMT, circulation, sensation, motion, and temperature on the extremity that's restrained. These are general guidelines. How about body mechanics? Has anybody reminded you these first 4 weeks to please raise the bed, work at a level that's working better for you?
Every day.
George would remind you, your back is important, that you keep yourself safe. So don't bend over and raise the bed to the level that's good for you. If you have a heavy patient, don't try to maneuver him by yourself. Get some help. Do a lift. Do whatever you need to do to save your back. Back injuries are a major problem for nurses in terms of disability. And then the last slide is home safety. Sometimes people will go into the home before the total hip or the total knee replacement patient is ready to go home, and they'll evaluate the house for safety. I think that's with Module 4. We're done. Yay! Next week, Module 12, and then you'll have Exam 2. And half of the semester will be over. No, you get 2 school days off. Actually, you guys get 1 day off on Monday. Don't show up on Monday, but do come here on Tuesday at 7 a.m. Do what? Guys.